Indocyanine. Today we will study about indocyanine green angiography. The history of the ICG. Koger and Kromkos, the two scientists, used ICG to study the hemodynamics of the monkey or the dog brain, and they discovered the choroidal vasculature using ICG in 1970. The first human ICG angiogram was done using the carotid artery. Robert Flower, another scientist, first developed the technique of the first intravenous fluorescence ICG in 1972 and then in humans in 1976. Hayashi in the mid-1980s improved the filter combinations which increased the sensitivity for the near-infrared wavelengths also introduced video angiography. In 1989, Schaeder and Schroeder used the scanning laser ophthalmoscopy for the ICG video angiography. Januzzi recently discovered 1024 line resolution system, high resolution and long duration of ICGA with flash synchronization. When to do ICGA: Core principle for any diagnostic retinal images, we have to select the technique that best visualizes the disease and investigation. Why to do it? ICG is suitable for visualization of the choroidal circulation because the near-infrared light absorbed by the dye could readily penetrate through the most ocular tissue, including the retinal pigment epithelium and the zentrophil pigment found in the macular area of the fundus. Secondly, it binds to the plasma protein and does not leak through the fenestrated choriocapillaries. Thirdly, it is a very safe dye, safer than the fluorescein, and it was FDA approved in 1959. About the dye, the ICG is also known as Fox green because in 1957 to 60, Dr. Fox at the Mayo Clinic first used this dye for recording the time-varying ICG dilution in the whole blood in the field of cardiology. It is a tricarbocyanine dye and it is an anionic dye. Its molecular weight is 775 daltons. It is soluble in highly distilled water, but it still needs protein binding for the stability. General principles. The first general principle of this ICGA dye which helps it differentiate from the fluorescein dye is the binding. This dye is 98% bound to proteins, especially the globulins like the alpha-1 lipoprotein compared to the 85% binding of the fluorescein. Hence, there is less leakage from the choriocapillaries. Second general principle of this dye is fluorescence. It is much less than fluorescein dye. The excitation peak for ICG is 790 nanometers and the emission is at 835 nanometers. This allows better penetration through the pigments. The filters used for ICGA are the infrared barrier and excitation filters. The half-life of ICG is 3 to 4 minutes in comparison to the plasma half-life of fluorescein, which is 23 to 30 minutes. The excretion of ICG is by liver in the bile, whereas the metabolism of fluorescein is by both liver and kidney, and it is excreted in urine. The ICGA has 5% sodium iodide to enhance its solubility. The procedure to do the ICG angiography is we mix the 25 milligram dye in the vial with the 5 ml of the aqueous solvent available in the dye and make the concentration to 5 milligram per ml. The color, red-free, green-free and the control photographs are taken, after which the dye is injected in the antecubital vein of the patient. After the injection, the 5 ml bolus of saline is flushed through the vein and the images are clicked after 8 to 10 seconds of the injection. After this, the images are clicked after every 8 to 10 seconds till a blooming occurs. Blooming refers to the same concentration of ICGA in the retinal and the choroidal vessels. After the blooming, the images are taken at the 3rd, 5th, 7th, 10th and at the 25th or 30th minute. The imaging systems used for ICGA angiography are of two types, either the conventional high-resolution digital imaging systems or the scanning laser ophthalmoscope-based systems. The conventional high-resolution digital imaging system fundus cameras have white light usage, whereas in the scanning laser ophthalmoscope-based systems, The light source is a monochromatic laser. In this scanning laser ophthalmoscope confocal systems, a pinhole aperture is present. A pinhole aperture is present, which blocks the reflected or the fluorescent light outside the focal plane, and hence it helps in the better quality images, and simultaneously FFA and ICGA is possible using the confocal SLO systems. Here is a comparison. This is a picture showing the dynamic ICG done by the scanning laser ophthalmoscope, where we can image the choroidal vessel, getting filled up and the retinal vein getting filled up in the case of retinal angiomatous proliferation stage 2. And here is the same case imaged with the help of conventional digital angiography, and hence we can easily see which is the better imaging system. The sequence of vessel filling by the ICGA can be demonstrated with the following pictorial diagrams. First, the larger choroidal vessels in the hallux layer of the choroid are filled, which can be seen which are marked by these yellow arrows, and this is during the early arterial phase, the corresponding to the early arterial phase of the of the fluorescence. After that, the smaller choroidal vessels in the sacculus layer of the choroid are filled, which are shown by the green arrows, and which correspond to the arterial phase of the fluorescein angiogram. And after the larger and the smaller choroidal vessels are filled, then comes a turn for the choriocapillaries to get filled, as shown by the blue arrow, which corresponds to the arteriovenous phase of the fluorescein angiogram. Phases of the normal ICG angiogram are very early. In the very early phase of the normal ICG angiogram, the disc hyperfluoresces. There is poor perfusion. There is poor perfusion of the vertical zone, which is known as the watershed zone. This is a watershed zone above and below the optic disc. Then there is a prominent filling of the choroidal arteries. And the early filling of the retinal veins. Filling of the retinal arteries, but not the retinal veins. After this comes the early phase at 2 to 3 minutes. There is the filling of the watershed zone. Fading of the choroidal arterial circulation, but there is a prominent filling of the choroidal veins, which we can see here. There is maximum choroidal stromal fluorescence due to the impregnation with the ICG dye, and there is the filling of both, and in the retinal vasculature, both the arteries and the veins are filled with the ICG. And then comes the late middle phase at 6 minutes. There is reduced filling of the choroidal vessels, that is, choroidal vessels begin to empty. There is diffuse hyperfluorescence due to the leakage of the dye in the choriocapillaries. There is persistent filling of the retinal vessels. After this comes the late phase at 28 to 30 minutes, in which the large choroidal and the retinal vessels are empty. Therefore, the choroidal vessels appear dark. Because of the diffuse stromal background hyperfluorescence. Interpretation of the ICGA. It is more difficult to interpret than FFA, as both the retinal and choroidal circulations superimpose. There is nothing called as window defect or the transmission fluorescence in ICGA, because RP is not a barrier to this dye. Standard angiograms as those exist in fluorescein angiogram don't exist here. The resolution of ICGA is 11 micrometer, which is more than the size of the choriocapillaries and the choroidal vessels. Hence, all the choroidal vessels can't be imaged together in ICGA. Causes of hyperfluorescence in ICGA. If in ICGA we see a hyperfluorescence in the early phase, then we look for the what is the fluorescence in the intermediate and the late phase. If in the intermediate and the late phase the lesion is hypofluorescent, then it points to the partial thickness choroidal lesion, for example the granuloma. But if the lesion is hypofluorescent in the intermediate phase and becomes isofluorescent in the late phase, then it can be due to the blood fluorescence due to the nevus or hemorrhage, chorioretinal atrophy in myopia, choriocapillaris non-perfusion, for example, in the white dot syndromes like APM, PPE, or the MEWDS, and full thickness stromal lesion, for example, a granuloma or the tumor. Causes of hyperfluorescence in Icga: it can be due to the pseudofluorescence, for example fibrosis; optic disc hyperfluorescence, that is seen in the cases of severe inflammation, for example VKH; retinal hyperfluorescence seen in Behçet's Birch's chorioretinopathy. Then the true choroidal hyperfluorescence is seen in abnormal vessels, which can be seen in CNVM; leakage of vessels seen in choroidal inflammation; vessel staining in the early phase Icga in the severe choroidal inflammation; and the tissue staining in the late phase in the granulomatous diseases. Now the first indication for the Icga is CNVM. CNVM is of three types: the occult CNVM or the type 1 CNVM, the type 2 CNVM is the classical CNVM, and the third type is the type 3 CNVM. Now the occult CNVM can present with pigment epithelial detachment or without it. The occult CNVM has subtle membranes which are undetectable on the FFA but can be easily picked up on Icga. The pigment epithelial detachment appears on FFA as hyperfluorescent lesion in the late phase, therefore obscures the pathology of the underlying CNVM. Icga images the choroid below the pigment epithelial detachment and can be helpful to classify the pigment epithelial detachment into serous versus fibrovascular versus hemorrhagic. And Icga-mediated photodynamic therapy in non-responsive patients to anti-VEGF is the treatment of choice nowadays. This is the occult CNVM can be occult CNVM occurring can be divided into those occurring with the fibrovascular PED and those occurring with the late leakage of undetermined source. The fibrovascular PED constitutes 22 to 50% of the occult CNVM, and this shows the fluorescein angiography of the well-delineated neovascular network located along the edges of the pigment epithelial detachment. And in the Icga, we are now confirmed about the pigment epithelial detachment, and the CNVM is also very well delineated. After this is this is another example of fibrovascular PED, where the fluorescein angiography shows the occult CNV along with PED. Very early ECG shows the feeder vessel originating in the juxtapapillary area and the pigment epithelial detachment shown because of the hypofluorescence. And in the late Icga, this pigment epithelial detachment, this is a pigment epithelial detachment which hypofluoresces, and the feeder vessel feeds into the retinal vein. After this, the late leakage of the undetermined source constitutes 36 to 78% of the occult CNV. In the fluorescein angiograph, we see the leakage of the dye in the late phase, and the same thing in the Icga in the late phase will show as occult CNV because of the leakage in the choriocapillary area. In the one-fourth of the patients with late leakage of undetermined source of RAP, in the fluorescein angiogram we see that there is a leakage present at two places in this patient. But when we do the Icga, we are very much sure that this is a case of retinal angiomatous proliferation along with PED. The type 2 CNV: this patient has on the fluorescein angiogram leakage from the lesions which obscures the boundaries of the neovascular network, but on the Icga the limits of neovascularization are much more visible along with the central feeder vessel with surrounding network of new vessels. We can easily make out the new vessels. This is an example showing example of the patient who had on the red-free images the intraretinal blood within the central atrophic area. A small subretinal hemorrhage is also present inferiorly. This patient's FA shows demonstrates late leakage of the undetermined source along the inferior edge of that optic atrophic area. Along with this, if we look at the early ICG of this patient, it reveals mature large choroidal vessel feeding the large net of neovascularization and along the inferior edge of the central atrophic area, and a real chorioretinal anastomosis can be seen. If we look at the late phase of the ICGA at 4 minutes, the draining choroidal veins are well visualized as in the neovascular network inferiorly. That is shown by these open circles. But when we used anti-VEGF in this patient, there was increase in the size of the central retinal hemorrhage, showing non-response. The ICGA can be used to distinguish between the retinal angiomatous proliferation versus the polypoidal choroidal vasculature, that is the PCV. The RAP lesion is a type of type 3 CNVM. The three stages of RAP are stage 1, that is the intraretinal neovascularization, stage 2, the subretinal neovascularization, stage 3, the retinal choroidal anastomosis. The treatment for the stage 1 and the stage 2 RAP lesion is a laser photocoagulation of the retinal vessels, whereas in the stage 3 retinal choroidal anastomosis, we have to give ICGA-mediated photodynamic therapy plus anti-VEGF agents. When associated with pigment epithelial detachment, the RAP is usually well within the area of the detachment and not at the edges of the detachment, as is typically seen in the case of CNV. In the CNV, we have the leakage point, that is the lesion at the edge of the pigment epithelial detachment, but in the RAP lesion, it is not at the lesion is not at the edge of the PED, but within the center. So what is PCV? PCV is the inner choroidal vascular network of vessels ending in an aneurysm bulge or the outward projection, which is visible clinically as a reddish-orange spheroid polyp-like structure. It is a type of CNV which corresponds 50% of the CNV cases in the Asian population. It presents with subretinal hemorrhage and pigment epithelial detachment, and its main types are hemorrhagic versus fibrovascular. Fundus fluorescein angiography doesn't pick up the lesion. ICGA outlines the areas of the polyp like the outgrowths of the choroidal vessels. And the treatment for the PCVA is ICGA-mediated photodynamic therapy plus anti-VEGF. In the PCV can be divided into juxtapapillary, macular, and the extramacular PCV types. In the juxtapapillary, we can see we in this patient of juxtapapillary PCV, we see in the late phase of FA shows a neurosensory detachment, with multiple juxtapapillary hotspots. The early and the late phase of the ICGA shows the detachment along with juxtapapillary PCV. In the macular PCV, the late phase of the FA shows type 1 occult CNV, with the pigment epithelial detachment. But in the early and the late phase of the ICGA, there is distinct network of vessels within the macular choroid, which ending in the two hyperfluorescent polyps. In these two hyperfluorescent polyps, one of the two is located within the pigment epithelial detachment. Then is the extramacular PCV. In the early ICGA, it shows a hypofluorescent lesion. Which remains hypofluorescent in the late ICGA. The second indication for ICGA is CSCR. The first was CNVM, the second is CSCR, that is the central serous chorioretinopathy. It is a self-resolving disease. Spontaneous recovery occurs in 60 to 70% of the cases. Recurrent and non-resolving cases have permanent vision loss and metamorphopsia. The ICGA demarcates points of choroidal hyperpermeability. and the points of leakage are much more less in fundus fluorescein angiogram than in ICGA. The low fluence or the half-dose PDGA on the leakage points is the treatment of choice. ICGA helps to prognostic the patients of chronic CSER. The response is that the clear areas of the choroidal leak respond better than the diffuse choroidal leakage. This picture shows the fluorescein. This picture shows the fluorescein angiogram having three distinct serous detachments and one point of leakage. Another hypo and one point of leakage. Another hypofluorescent area is visible, but it is not clear if it corresponds to another point of leakage or represents an additional detachment. Hence, we do the ICGA to confirm whether it's a point of leakage or just corresponds to another detachment. Hence, in the early ICGA, we saw that we saw the detachments are hypofluorescent and the leakage are hyperfluorescent, which is not still seen in this early ICGA picture. But in the late ICGA, there is marked leakage in the late phases from those two spots. Then we can see in this picture of the patient has the fluorescein angiogram shows only an area of pigment epithelial disturbance here. But in the ICGA, there is a more extensive alteration of the choriocapillaries with multiple areas of hyperfluorescence. This is the case of CSER. Then the third indication is choroidal tumors. The longer wavelength of the infrared helps us to image the mass lesions. The melanoma, metastasis, and hemangioma can be imaged using ICGA. The circumscribed choroidal hemangioma in the early phase shows the vessels filling in the tumor and the late washout phase surrounded by the hyperfluorescent rim. The treatment of the choroidal hemangioma is ICGA-mediated (PDT). The tumor regresses, that is, the hemangioma regresses, and the subretinal fluid resolves. This is the picture. This is the fluorescein angiogram picture showing the features of the choroidal hemangioma, which is a hyperfluorescent mass seen in the early FA and in the late views. This is the ICGA of the same patient of the choroidal hemangioma. The early phase at 49 seconds show the finely lacy vascular network of the intrinsic vessels. The ICGA at 2 minutes and 5 minutes show the increasing hyperfluorescence of the lesion, and the margins of the tumors are not regular but scalloped. And the late phase of ICGA shows the hyperfluorescence within the tumor, that is the washout effect, surrounded by the hyperfluorescent rim. The halo of the minimal hyperfluorescence surrounds the tumor. This may result from the staining of the RPE or the leakage of the ICG into the subneurosensory retinal space. The choroidal melanoma on ICGA can be seen as the tumor's intrinsic vasculature is visible, which is irregularly tortuous and has anarchic branching. There is strong fluorescence within the large choroidal vessels around the lesion, which is a possible sign of increased flow due to the presence of the tumor. The fluorescein angiogram of the same patient show melanoma. The intrinsic vessels are so leaky that the pathology can't be made out, hence not identified, and the inferior and the next indication is the choroidal inflammation. The inflammation can be of the choriocapillaries, which present as hypofluorescence in both the early and the late phase, or the stromal choroiditis, which present as a hyperfluorescence in the early phase but hypofluorescence in the intermediate phase. The late phase can either be hyperfluorescent or hypofluorescent depending on whether it's a partial or a full thickness granuloma. Multiple evanescent white dot syndrome. In this choroidal inflammation, uh, in this disease having the choroidal inflammation, the late phase of the FA shows only mild alteration at the level of outer retina and the RPE, but the early ICG also began to reveal the areas of hyperfluorescence, or sorry, began to reveal the area of hypofluorescence, and in the mid and the late phases of the ICGA, there are more areas of decreased hypofluorescence become more evident. In the serpiginous chorioretinopathy, the lesion in the ICGA has extent much more than that seen in fluorescein angiography, and this indicates a progression of the pathology that can be anticipated or predicted using ICGA much before than FA. This is the patient diagnosed as Azure complex on fundus autofluorescence and the OCT images. The fundus autofluorescence has typically increased autofluorescence, that is the hyperfluorescent areas around the optic disc, and the corresponding OCT shows the loss of photoreceptors corresponding to these hyperfluorescent spots. The fluorescein angiogram of these patients show hyperfluorescence in the same areas, whereas in the ICGA, in the early phase, there are no alterations and it appears normal, but in the late phase, there is increased hyperfluorescence. The last stage after the choroidal inflammation is the chorioretinal atrophy. Chorioretinal atrophy changes in the Stargardt's and the dry AMD can be differentiated using the ICGA. The fundus autofluorescence of both the diseases look similar. That is, the both the cases have show the hypofluorescent areas of chorioretinal atrophy, hypoautofluorescent areas of chorioretinal atrophy. But if we do the ICG of these patients in the Stargardt's disease, these lesions remain hypofluorescent in the late phases of ICGA, but in the dry AMD cases, these lesions become isofluorescent in the late phase of ICGA. Coming to the adverse effects of indocyanine green angiography, it occurs in only 0.15% of the patients. The adverse effects are both mild and transient. The ICG dye is much safer than fluorescein. Hot flushes, tachycardia, nausea, hypotension, and vomiting are very rare, and death is reported only in 1 in 333,333 patients. The contraindications for ICG are documented allergy to the iodine, liver disease, pregnancy, group C drugs, previous allergy to the ICG, uremia, hemodialysis. Thank you. Have a wonderful day.